Bone scanning, a short educational video by Sanjeev Bagga MD. A bone scan is performed using technetium-99m labeled diphosphonates. 50% of the injected dose localizes in the bones 2 to 6 hours after IV injection. The bone agents adsorb to the mineral phase of the bone. The blood flow and rate of new bone formation determine the degree of bone agent uptake. Imaging is performed 2 to 4 hours after IV injection of 20 to 25 millicuries of technetium-9m MDP. This delay clears the tracer from the background and improves visualization. Patients are encouraged to drink a lot of fluids. Frequent voiding helps reduce radiation dose to the urinary bladder. Low energy, high resolution collimator is used, and anterior and posterior whole body images are obtained. High resolution images can be obtained. Urinary bladder activity, mild renal activity, and minimal soft tissue activity is normal. Bone uptake decreases with age. Persistent increased symmetric uptake is seen in the acromion and coracoid processes of the scapula, medial ends of the clavicles, junction of the body and manubrium of the sternum, and the sacral alae. Anterior and posterior whole body images of a bone scan in a child demonstrate intense symmetric uptake in phases of the long bones. Bone marrow containing flat facial bones show tracer uptake in children. Anterior and posterior whole body images demonstrate abnormal uptake in both the shoulders, ribs, vertebrae, femur, skull, sacrum, and pelvis. These findings are consistent with multiple areas of metastatic disease. Anterior and posterior whole body images of a bone scan demonstrate multiple fractures with linear uptake in bilateral ribs, H-shaped uptake in the sacrum, and in the right proximal humerus. Most fractures are visible on a bone scan within 24 hours. In older patients with osteopenia, bone scan may be negative within the first 24 hours and may become positive at 72 hours. Bone scans usually turn negative after 6 months of trauma. However, they can remain positive up to 2 years. Anterior and posterior images of the right tibia demonstrate an acute stress fracture. In acute stress fracture, there is increased blood flow and blood pool activity, and on delayed images, there is focal increased uptake. Anterior and posterior images of the bone scan demonstrate bilateral shin splints of the tibia. Shin splints are periostitis at the tibial insertions of tibialis and soleus muscles due to overexertion. The blood flow and blood pool images are normal. Delayed images demonstrate linear uptake along the posterior tibial cortex. Anterior and posterior images of both the tibia demonstrate Paget's disease. There is diffuse uptake in bilateral tibia, which are deformed and expanded. Bone scan shows hypertrophic osteoarthropathy, which is a cortical periostitis seen in intrathoracic tumors, pulmonary diseases, cardiac conditions, and intra-abdominal diseases. On this examination, there is non-uniform irregular cortical uptake involving the long bones. Bone scan shows reflux sympathetic dystrophy of the right hand. Typically on a bone scan, there is diffuse uniform increased uptake in the affected region. On the current exam, on the delayed images, there is periarticular uptake in the right wrist, interphalangeal and metacarpophalangeal joints of the right hand.